Atrial fibrillation, they basically we need to define a few terms. So they're talking about the first categorization relates to how it came on and how long it's lasting. And so their idea is they talk about first detected atrial fibrillation. Patient presents, this is the first time they've ever had it. Whether you know how long they had it or not is another matter, but it's the first episode. Paroxysmal atrial fibrillation comes in spells, generally lasts less than a week. You're not allowed to, less than a week. It generally converts within 24 hours in those people who have it. We're pretty familiar with that. Persistent atrial fibrillation is spells lasting more than a week. They tend to be more difficult to convert back. And then permanent atrial fibrillation, the people who are in it all the time, who are taking medicines to slow it down, and are taking anticoagulants as well to prevent them getting a stroke. The American College of Cardiology and American Heart Association and some Europeans have come together also and defined it based on the patients. And in their definitions, lone atrial fibrillation is basically atrial fibrillation occurring without any concomitant heart or pulmonary problems in a person less than 60 years of age. And those are the kinds that we're looking for. The people who we can treat, and particularly rhythm convert, if we can find them. The non-valvular atrial fibrillation says you've got it, but there's some issues that relate to your heart, but not your mitral valve, because rheumatic problems with the mitral valve, prosthetic heart valves, and mitral valve repairs predispose people, and so the etiology in those cases are considered to be related to the mitral valve. And then the last group is another group that we're going to try to find out. These people have atrial fibrillation as a result of some other problem. So we need to find that problem if we can. A lot of these problems relate to people's hearts, but they're not necessarily chronic problems. Like they could be a myocardial infarction, cardiac surgery. They talk about pericarditis, myocarditis. Myocarditis, when you think of myocarditis, what makes you think of that? Particularly in kids. You sometimes see this. They get these viral illnesses. They wind up getting coughing and short of breath, and you start hearing some rales, and their heart rate is faster than it should be for the degree of fever that they may have. And that's kind of the alerts to maybe this kid is developing some failure as a result of myocarditis, usually viral etiology. Sometimes these kids have very bad outcomes, and there's the source of some potential litigation. And so the idea is for the doctors to try to be kind of aware of that. They also talk about other things like hyperthyroidism, pulmonary embolism, pneumonia, and other acute pulmonary diseases as precipitants of atrial fibrillation, which you need to be able to find the cause and try to find it. There's also a longer list there. Hypoglycemia might be a cause. So you have somebody who has, for some reason, a low blood sugar. They're an insulin-taking diabetic, and they get out of control, and their blood sugar's in the 30s. And then there's this release of adrenaline trying to pull the glycogen out of the liver to increase the blood sugar. Well, that release of adrenaline may be also causing this person to have their vasoconstriction, so they're pale, clammy, tachycardic, and it may trigger this problem. Hyperthyroidism, we want to pick those up if we can. A TSH would be probably a reasonable thing to do in somebody who's got a atrial fibrillation for the first time, or nobody's kind of nailed at what kind this is. It's an easy test to do, for sure. A little bit more sophisticated is this idea of low potassium due to hyperaldosteronism. Aldosterone, sodium and water retention, whatever sodium does, potassium does the opposite. So you've got loss of potassium, which is an arrhythmogenic kind of factor in these people. They have high blood pressure and lower potassium. So you do a random comprehensive metabolic panel on these people. K comes back 3.2. Maybe that is now goes into the differential here. High blood pressure, low potassium. This may be one of the causes. Other causes of low potassium, are obviously more common, like diuretic use, which is also the cause of low magnesium, which is the next list here. People say, well, don't measure magnesium because it's all intracellular, and total body magnesium is not necessarily reflected by what's in the serum. But you could say the same thing for potassium. There's 30 times more potassium in the cell than outside the cell. We measure the stuff that is outside the cell, and we make some inferences between what's going on by, if your K is 3.2, we say, well, you're probably depleted. We're not sure of that, but it's probably the case. And so if you got a low mag, is it a measure? Maybe that, and you have atrial fibrillation, well, maybe that's the problem, because we measure one of these electrolytes, but mag is just as important in terms of the things that K does, mag does as well. They're brother and sister. It's called the forgotten electrolyte because it's not included on any kind of panel, but it's something to consider. Pheochromocytoma might be another thing. Now that obviously is going to be associated with generally really pretty high blood pressure, but that high blood pressure may have triggered this spell, but by the time they get to you, that high blood pressure is not there anymore. So, and if it's high when they get there, that's a consideration. Obviously, it's going to be, not on the top of the list. Then there's this business about alcohol. I saw an orthopedist come in around, it was around Christmas time actually. He had never had a problem before, and he was in atrial fibrillation. They call it the holiday heart thing. There's a thing there that says women are more likely to get it. It doesn't take very much. They're talking about 2 drinks a day. Middle-aged women who consume more than 2 drinks per day were 60% more likely to develop atrial fibrillation. 60%, it looks like a big number. Well, it might mean the difference between 1 and 1.5%, maybe 60%. So you can always make the number sound the way you want to. Caffeine, MSG, sleeping on the left side has been associated. There's a difference between causing and associated. So anxiety, stress, physical exertion, and viral illnesses or otherwise illnesses have all been associated with this problem, although we can't necessarily say we can prove that it caused it. As a matter of fact, one of the first papers here that talks about it is the cause is steroids being associated with atrial fibrillation. But sometimes these associations have got such strong components of them that it really makes you think, well, it must be the case without doing a randomized double-blind trial, which is, you're never going to do that to ascertain whether somebody's got steroid-induced atrial fibrillation. But in this paper, the odds ratio of you getting atrial fibrillation on steroids was almost 4 times greater than if you weren't. That's pretty impressive. And it was dose-related. The more you took, the more likely you were to get it. So people who, they said it was taking higher doses were more likely to get it, 6 times more likely to get it. Although, look at the doses that they talk about. High dose was considered 7.5 milligrams of prednisone a day. That's not high dose at all. So it kind of destroyed a little bit of the credibility right there. Risk was greatest in people newly on steroids. So if you have newly on steroids, more likely to occur on steroids, and if it is dose-related, maybe better numbers than this. You put all that together and said, it probably is cause of it. Our priorities are basically to slow the rate, find the cause, and consider converting the rate. In this subset that we're talking about, new onset, and we'll talk about how, and we'll talk about the drugs in the tomorrow's session. But first of all, we just basically want to do some of the more basic things. Now, most of these people are going to get some kind of cardiac workup in the emergency department. You're going to send off some troponin on these people. And when the troponin comes back high, or a little bit high, you're going to say, well, maybe this is a heart attack. This has triggered this atrial fibrillation. Well, the likelihood of that being the case is really quite small. And there's a bunch of papers here that talk about all kinds of things that have been shown to increase troponin. Even though it's supposed to be very specific for cardiac problem, leakage of this marker out of there, there are some things that are cardiac related, but there are a whole list of things that don't seem to be cardiac related. They're associated with increases in troponins. And atrial tachycardias, whether it be atrial fibrillation or atrial PAT, have been associated with elevated in the troponins. So the idea here is not to get focused on this is maybe a heart attack. It's statistically not that at all. When you look at these papers, if you can summarize the cases, they're talking about myocarditis, pericarditis, cardiomyopathy, coronary spasm, aortic stenosis, all of these, and heart failure, and all of those things relate to the heart. Doesn't mean that it's necessarily ischemic, but what about things like renal failure, pulmonary embolism? There's paper number 3 there is on bacteremia being associated with elevations in troponin, electric shocks, strokes, strokes. What the heck is a stroke doing causing a troponin increase? But strokes also cause high elevations in blood sugar, all of this catecholamine surge kind of thing. GI bleeding, DKA, and exacerbations of COPD. So I believe that this is very, very, very specific for, leaking myocardial tissue kind of thing. It's difficult to connect the dots on why a DKA would be having, a troponin leak, but the literature is full of these papers that talk about this. Generally, when people have elevations in troponin, no matter what the condition is, the outcomes tend to be worse than when they're not. The idea that we're going to give generally a calcium channel blocker to treat these patients to slow this rate is we have two issues: dropping your blood pressure and making CHF worse. Because these calcium channel blockers decrease the force of contraction, and maybe that will be an issue in this patient because some of them will either have pre-existing failure or the AFib itself caused the failure. Your heart's going 140 minutes, you don't have any atrial kick anymore. You may have, some borderline, coronary issues, and the next thing you know, these people present shorter breath, even after a relatively short period of time, a couple of hours. It's amazing the distribution of the symptoms. Some of these people are totally unaware that they're fibrillating. They don't feel it, they don't have any symptoms of any consequence. Maybe they have felt some palpitations, went to the ER, and others are substantially symptomatic. So this idea about trying to avoid these problems of dropping blood pressure and making failure worse always brings in this issue about which drug and, adding some calcium to these fix these problems. So number 8 is from the Stone Age, 1994, diltiazem versus placebo. Diltiazem versus placebo. New York Heart Association 3 or 4. 3 is defined as marked limitation of physical activity. They're comfortable at rest, but less than ordinary activity causes fatigue, palpitation, or dyspnea. And the 4s, unable to carry out any physical activity without discomfort, symptoms of cardiac insufficiency at rest. If any physical activity is undertaken, discomfort is increased, shortness of breath kind of thing. Well, they used, in this placebo-controlled study, diltiazem versus placebo, they found no patient had a worsening of their CHF when they give them diltiazem. So that's the belief that this drug is better than verapamil in this regard, causing less of a problem with regards to blood pressure and making failure worse. 9 is a diltiazem study. Is it substantially superior to verapamil? Now that was an issue in the past where there was a substantial price difference, but that's not going away. This is a small study, 17 patients. Diltiazem worked faster. Verapamil caused life-threatening hypotension. And one patient had a FEV1 of less than 20%. So why use verapamil? Although there have been in the past lots of papers that said, we used it, we gave it 5 milligram, 5 milligram, 5 milligram, 5 milligram. We pre-treated with some calcium. We after-treated with calcium. We didn't have this drop in blood pressure because they make a distinction between these calcium channel blockers having two effects that are separated, this slowing of the heart effect versus this CHF hypotension effect. So that if you can treat one with calcium, you'll still get the antiarrhythmic effect. And that's kind of the way it's been done for a long time. What about calcium and diltiazem? Now this drug probably doesn't maybe need that very much. Number 10 is a good paper, calcium before IV diltiazem. They note that hypotension has been reported in about 1 in 5 cases of people given this drug. And so what about giving a little pre-treatment to prevent hypotension? Well, there's no statistically significant change in the blood pressure, a drop of 8 with calcium and a drop of 14 with placebo. Not statistically significant, 6 millimeters, no big deal. They were pre-treated with 3.3 mLs of calcium chloride. Sometimes people wonder how much, because everybody in the room should know that that's something to consider to give somebody who you're trying to slow the rate and you're a little concerned about where the blood pressure has gotten to in these patients. And so since that is common done, some people make a distinction between calcium gluconate and calcium chloride. So, they said, calcium gluconate, it takes longer to separate these, positive ion from the negative ion, and so calcium chloride is faster and better. And it doesn't seem to be the case. Yes, calcium chloride has 3 times more calcium than does calcium gluconate, volume for volume, 10% and 3 mLs, 10%, 3 mLs. But they dissociate immediately. It only raises the calcium very transiently. They're talking about last minutes. And so there's really no distinction between these two, except in the absolute amount of ionized calcium that you can give. 3 versus 3, you're giving more. But some people prefer one over the other. Calcium chloride tends to be used, but the idea is you're not supposed to infiltrate have your IV leak when you're taking calcium chloride because of some issues regarding skin issues, necrosis. Magnesium, does it have a role in the management? It's really interesting. Any of you use magnesium? Are you Australian doctors? Thank you very much. Because when you read these papers, except for one of them here, this would probably be the drug that you would use more frequently than anything. Papers 11 to 16 look at the utility of magnesium in controlling AFib. 11 says it was as good as diltiazem. But all the papers on magnesium say if you're looking at conversion of rhythms from AFib to sinus, you'll get a lot more conversion if you use magnesium. Is that your experience? Everyone that looks at that basically says the same, except one paper here which has some problems, which I'll show you. So here's one. Good as paroxysmal AFib for less than 12 hours. One of the recurring themes is the faster that you try to convert this, the more likely you will be successful. And the longer it goes without being converted, the harder it is. They gave a routine kind of dose of magnesium. Certainly was not aggressive. 2.5 milligrams of mag was given over 15 minutes, and they gave them 7.5 milligrams over the next 6 hours. It was only 23 patients. Diltiazem was given in a bolus, and then they followed with a drip. They only gave 1 shot. Maybe that was an issue. Magnesium levels were normal at baseline, and that comes up all the time. It doesn't matter whether your magnesium is low or high, well, I guess if you have kidney problems, it might be high. But there's no point in measuring it if you're going to use it to treat somebody, because you don't measure their calcium when you give it calcium to treat somebody. If you're going to give it works quickly, and then it goes away. Excess magnesium is excreted through normal kidneys. So the idea of should you know what it is in advance, most people cannot make a very compelling case for that, because magnesium levels are usually normal, even though when these given therapeutically, it tends to work. Neither group developed clinically significant hypotension, nor magnesium nor diltiazem. Heart rate decreases were similar, but at the end of 6 hours, 13 of 23 given magnesium had converted, only 5 of 23 given diltiazem converted. That was statistically significant, and on the face of it, it looks like it would be as well. So there is this idea here. What about magnesium versus amiodarone? Now that's putting up this puny little electrolyte versus the gorilla of antiarrhythmics. Come on now, that's not fair. They compared a 5 milligram dose of magnesium followed by a drip that's listed there versus giving some amiodarone. 42 critically ill patients with atrial tachycardias. Heart rates decreased by a mean of 19 in the first 30 minutes with both drugs. So that's consistent with the prior paper. 40% converted to sinus within 2 hours of both. But amiodarone is given, because it does 2 things. It slows rate, but it's given to convert them. That's what it's given for. It's not primarily given to slow the rate, but here it slowed the rate as much as magnesium did. But it's a converter. We don't use it. You don't give it people who you're trying to slow them down, amiodarone. You give it to people you're trying to convert. So 40% of both groups converted within 2 hours, but at 12 and 24 hours, the conversion rate with MAG was better than amiodarone, 60% versus 45% at 12 hours, and 70 and 80% versus 50% at 24 hours. So here, the gorilla is being taken over by the forgotten electrolyte. There are 3 newer papers, 14, 15, and 16. One of the Australia paper, 14, they're still doing DIDs down there. Come on, you guys aren't doing that. Well, actually, what a lot of these papers that are quite old, they look at DIDs being routinely used to slow heart rates. Well, nobody does that anymore except the Australians. I'm sure you do other things that are better. But that really only slows your heart rate down while you're at rest. As soon as you get up to move the trash cans, your heart rate goes right back up to where it was. It's no longer 80, it's now 120 again. So here's this comparison. Aside from the fact that they used Driginus, the addition of magnesium drove the pulse a little lower than with Dig alone, and more patients converted. That's the key thing. 27% versus 12% converted in this study. So it's consistent with all the others. Magnesium causes a little vasodilatation, so you get this flush. That's probably the worst thing. And the worst paper here is 15. But to be fair, we should try to look at this. This is a paper where it's compared magnesium with placebo and found there was no difference. Well, how could that be? How could that be? An Australian study again, randomized 48 adults, paroxysmal atrial fib, less than 48 hours. That 48-hour number will become very important tomorrow. Patients only got an initial dose of magnesium and no infusion. Well, that's not the way you give that stuff. You give it 2.5 grams, and then you infuse it. So they didn't do that. No significant difference in heart rates or conversions, but my contention is they didn't give very much MAG at all. I like 16 the best. It's an 8-study meta-analysis published in 2007 involving 476 people, IV MAG or other drugs that we use like verapamil, diltiazem, amiodarone, Agmaline, never heard of that one. You guys use that in there? No. Or placebo. The initial MAG dose ranged between 1.2 and 5, so nobody really got over 5. 5 is pretty aggressive dose to begin. And then to give them some infusion that's listed there. Sufficient rate control, as defined by them, was more common with MAG. 61% achieved a sufficient rate control with MAG versus those other drugs. Conversion to sinus was also more common with MAG. The odds ratio was 2.3 times more likely to convert with MAG than with these other drugs. With placebo or calcium channel blockers. They excluded amiodarone in that subset. And the overall response with regard to rate and rhythm was better with MAG, 86% versus 56%, and it was faster. So this is a pro-MAG study, if there ever was one, combining 8 trials, almost 500 people. MAG levels at baseline did not correspond to the treatment response to MAG again and again and again and again. What else here? Last thing here is beta blockers. This study, number 17, double-blind comparison. How many of you use routinely beta blockers in these cases? Which one do you use in particular? Sotalol or Metoprolol? Metoprolol back here too? The 17 is a double-blind comparison of diltiazem. You know, everybody uses that. Or metoprolol on 40 people with rapid AFib. Unfortunately, this study excluded a lot of people who they didn't want to give metoprolol. Class 4 heart failure, well, you know, that might be an issue. Asthma, diabetes, COPD. These are people who are not traditionally excluded from getting diltiazem. They throw them out. Diltiazem was minimally faster and slightly more effective, but not to a statistically significant difference. So reducing the heart rate with metoprolol seems to be okay. Although I think by far most physicians have more experience with the calcium channel blockers. I don't want to start into the next part until tomorrow. So any questions, comments, disagreements? Okay.
Dose of MAG, and then the next 6 hours they're admitted or something, you know, they just start them on calcium channel blockers.
Well, first of all, you have to say, is anybody using MAG? So one doctor here said they're using MAG. The point of these papers is to say, this drug should be part of the armamentarium that you choose. The problem is that the other drugs are so good, but what they don't do, to the extent MAG does, is they don't convert people. And the papers that look at this, they don't convert people to the extent that these other drugs do. And tomorrow we're going to talk about why you should consider, in the emergency department, converting people who meet certain classifications. Surprisingly, not excluding a tremendous number of people. And then whether you could just send them home. And do any of you do that? Yeah. I bet you. Well, there will be the issue of what cardiac studies do these people need,
Yeah.
and over what time frame. And we'll talk more specifically about that.